So joining me today is Leslie Wittenrood. She is the Pulse Program Manager for the California Emergency Management Services Authority. Leslie and her team are on the front lines with supporting Pulse. And so she can speak quite authoritatively to what it has taken from inception, from concept inception to actually activating that service. Also, Norma Belcher is the Executive Director with the Texas eHealth Alliance. And Norma's really been championing with the state and the legislature to support Pulse, and just really dynamic, which you'll see soon enough, the Dynamo team. And Kristen Finney, who is the Senior Program Analyst at the Assistant Secretary for Preparedness and Response. She is also the Program Manager for Empower, which is a really amazing tool. And these three ladies have been really major contributors to the Pulse Advisory Council. I think I mentioned that we formed the Advisory Council because guess what? We are not experts in emergency response, but they are. So we realized very quickly we wanted to make sure that we included them on the council and guide its work. So I'm going to give a super short introduction to Pulse. I'm going to invite Leslie up because I really think you all need to get a sense of what they've done in California at a more substantive level. So why did Pulse come about? Well, years ago, you all recall, I think it was back in 2009, Hurricane Katrina hit, and there was a huge issue that so many people were impacted, displaced, and seeking care in shelters that there was just a shortage of information that was available about them, from the very, very basic information such as prescriptions that they might be on to just anything around their health history. And it was a problem, and it was something that HHS quickly realized needed to be rectified. And so it was then through really a series of other activities that took place which led to where we are today. I think Leslie's organization hosted the first emergency response HIE conference a couple years ago that was followed by some grants from HHS Idea Lab to map out an architecture, a potential architecture for that service. And then there were funds awarded to California to actually build that. An audacious inquiry, Jeremy, who is here, is part of that key effort. Thank you, Jeremy. Was to actually build, to prototype and build and operate Pulse. And that really led up to the point of last fall when the California fires started. And that's when Sequoia got involved. And we realized that in California they were trying to establish connections to Pulse health system by health system. We said, well, wait a minute, there's a national network. Why don't you just plug into the national network? And so within a few short days that happened, and we were able to stand up and support that activity. And then what we realized is that there is an opportunity to expand the support of Pulse to other locations, other states. And so given our history of being a steward for things that are incubated by others, Sequoia was really honored to have the opportunity to be a steward for Pulse and to expand it further. And so that took place in January of this year, and it was just in time. We formed the Advisory Council and started preparing, and then of course this spring was when the fires broke out in California, and again, we were called to serve and to help our colleagues in California. And I can tell you that the Sequoia team and the AI team, nights and weekends, deep dedication to making this work. But the great thing about this is we're not reinventing the wheel. Pulse basically connects to the national backbone of interoperability. So here are the other representatives on the Pulse Advisory Council. You can see we have a good mix of healthcare provider organizations and HIEs and subject matter experts. And so what does Pulse do? It essentially gives volunteers who are treating people who have been displaced and or cannot receive care in the regular care setting access to their health records. And these are actual pictures of Houston where there were actually a shelter set up in the stadium, in Houston Stadium. You can see it's not a very sophisticated arrangement when people are seeking care in these shelters. It's literally a table and papers, and you have volunteers basically greeting and helping folks out. So how does it work? Basically, it's each volunteer is credentialed with the state, so only authorized credentialed volunteers are able to treat individuals in the event of these disasters at these various facilities, and they are actually called to report to duty. They're deployed, is what it's called, and they are requested to report to particular facilities. These are alternative care facilities. And so when they arrive at that facility, they log into Pulse using their state credentials. It single signs them on to the Pulse system. Pulse authenticates against the state's database, and then the volunteers are able to search and access records. This, again, is another picture of an actual facility. I think this might have also been Texas. I will not do justice, which I'm so glad Jeremy's here if you all have architectural questions. But it's actually pretty simple, so let me know how I do, Jeremy. All right, so Pulse basically is made up of 3 components. One is the part that is the single sign-on component that interfaces with the state's volunteer database. So the idea was the missing link in this entire equation with Katrina and everything else is the volunteers may not have access to electronic health records when they're treating individuals in these other settings, and similarly, only individuals who are authorized and credentialed by the state can treat people in these facilities. And so this solves that. And so by integrating Pulse to the state's database, that's really the key missing link. And then the other middle part of that is the message broker. And so that's where the queries are sort of facilitated. So, and then it fans out to HIEs, or in this case, the eHealth Exchange was how they connected and brought back. And then there's a directory. And so in the case here, of course, it's, I think in California you have your own healthcare directory. We're looking at making this sort of a national level product, and it would be based upon the FHIR directory supported by Sequoia. So the idea, again, is Pulse is really, if you think about it, is the missing link in connecting to the states, and it plugs into the national backbone. And that is seen, of course, in this case, is connected to the eHealth Exchange. And then as the eHealth Exchange becomes a carrier quality implementer, it will enable Pulse to also connect to all of the carrier quality sites as well. And this is the workflow for an individual seeking treatment. They usually arrive, they're triaged. The person who's greeting them will really take their demographic information, query the information. Because the individual is present, they can actually help disintermediate their identity, and then they can initiate a query, and then it's presented and viewed by the volunteer. And so we'll just show, these are the actual screens for Pulse. So when the system is activated, it's actually, you can see a button there. And it's terrible because I don't have my glasses on, so I'm guessing on this. So I see the big red button, so I know it's a lock-in. Sorry. And then they select the facility where they're reported. And they could have to report to different facilities at different points in time. So again, they're mobile, and they have to go where they're reported to. And then they would basically enter basic information, demographic information about the patient who's there. This is, again, likely a triage person. It could be a non-clinician. And then they select the information. You can see there could be different records that are brought back for patients who are actually different individuals, so they can select the records which apply. And then they retrieve them. Now, these are basically staged so that when the individual is actually seen by a clinician, they're available for view. And that's basic medication history, allergies, meds, et cetera. How'd I do? Okay, good. So that gives you just a basic overview of Pulse. We do have the experts here afterwards if you want to get into more details, but I'd like to invite Leslie up so she can share a little bit more on what their efforts have been. Just the big green arrow.
Well, thank you for having me. Pulse has been a very exciting and rewarding project to be working on. Where am I?
It's a big green button and big green
The
arrow.
big one.
Big
All
one,
right. So I'm not going to go through the background. There's a lot of content in my slides. I'm going to kind of roll through them pretty quickly, but everybody's very eager for information on Pulse, and I believe the slides are going to be shared for you guys to have after the presentation, so that's why there's a lot of content. As Marianne, explained, I'm not going to go through the history of the funding. Today, in 2018, we have received new funding from CMS for several projects that we're working on in California, and one of those priorities is to expand Pulse from its pilot stage that it was formed in California. So she talked about the IDEA Lab and the patient and provider landscape for the project. So as you see, one of the things when it came about for Pulse, everybody thinks of the big things, earthquakes, different types of disasters. And yes, historically, we do have earthquakes, as you can see, that happen in California. But also, we have tsunamis in California. We also had, while we were right in the middle of developing the software, working with AI on this, we had Oroville, we had flood evacuations where we had patients. It was very frustrating developing this product and knowing that it could be used in so many ways in California, across the nation, and eager to get it ready. So in our design, Marianne talked about that. In California, we have a unique system where our disaster healthcare volunteer system, we actually utilize it for volunteers as well as other workers who want to go out and help in disaster situations. One of the things that was very important to us, though, was making sure we had a system that the health providers were licensed. And our system is checks every 24 hours to make sure all the providers are licensed. So for the pilot project, we started off with just using 6 of the licensed providers in the state of California. In phase 2, we will be adding more providers to that resource, as well as also not just disaster healthcare volunteers, but we're also going to be expanding, as you'll see in the disasters that have just happened in the last few years, hospital workers as well as other medical providers in the state who would be working in their regular environments but would have access to Pulse. So once we developed Pulse in late June of 2017, we actually held a tabletop exercise in Sacramento. We had 4 health information organizations for the pilot that were onboarding to the system. So we were going to check those connections. Ocprio, which is in Orange County, Santa Cruz, HIE, Sutter Health, as well as UC Davis Health Systems. So for the implementation portion of that, we got all the connections to work. We actually brought in end users to come in, focus groups, do some feedbacks. It was a 3-day. We were housed at Sac State for 3 days, working on the connections, looking at different things we wanted to make some changes with the software. We were in a very, very tight timeline. We had 2 years to design this, develop it, and implement this project. So when we did the tabletop exercise, that happened the end of June. We had less than 1 month to actually get it operable. So at that point, we made that goal. We still had some refinements that were going on with it, but fall of 2017 is really when it was ready that we could go ahead and utilize it. Now, that wasn't any of the updating of our policy manuals, ongoing procurements that needed to take place for sustainability or training or even communicating to our disaster healthcare volunteers and also to our locals that we had something. I refer to Pulse as an asset. That's how I view it in my world. It's an extension, just like when we go out and provide ambulance strike teams in a disaster, Pulse is another additional asset that we can provide communities in the state of California, and we'll be able to nationally to help in disaster relief. So here are some of the things with the implementation we were just starting to do when, of course, the wildfires of 2017 occurred. So, matter of fact, this hotel that burned down, at the time our chief deputy was on vacation, this was occurring. We had just attended a Redwood MedNet conference a year prior at this hotel. So I sent him the pictures while he was in Europe and said, look, the hotel we stayed at's burning down. What can we do? We've got Pulse. Can we look at how we could utilize it right now? So with the fires, we looked at what we could do. One of the things that was very frustrating at the time with the pilot, we only had onboarded 4 health organizations. When we went ahead and looked at the Napa and Sonoma fires and the demographics, we only had geographically in our database probably, I want to say it was 90 patients. We weren't even sure what zip codes, if even those patients were within those areas in some of the medical shelters within that span of those counties. So at that point, as the fires continued, it got worse. We were able to, and at the same time, and thank you to Dr. Lane, who was at the Sequoia board meeting, called, and I was actually at a commission meeting for our IMSA. over cell phones and emails, we were able to work with Sequoia and connect to eHealth Exchange on a temporary basis. We were able to make a lot of connections, expand that geographical base to be able to cover all our patients in California is what our goals were. So we were able to get that done. That was a beautiful thing to have happen. And we also at the same time had shelters that were repopulating people back. So we actually never got to go ahead and utilize it in the field at that time. So as you can see, it was over 250 major wildfires that were going on during that period of 2017 that went from October all the way into January. You can see how significant. These are some of our strike teams that were going through ash, moving patients, transporting them out of Sonoma. As you can see, during that disaster, Kaiser and also Sutter in Santa Rosa were evacuated as well, moving out patients. So one of the things people ask me is, okay, why don't you, when there's a disaster, just go out and just start using poles? Well, the problem with that is we follow a system where the locals actually ask the state for help. We don't go in and exert authority. We let the process roll up. We follow the standard emergency management system SIMS to make sure there's coordinated organization, mutual aid that is asked for is provided, and following IS procedures. So just a little bit more on that and the procedures. So when we're requested a mutual aid, this is kind of the map. We work with Department of Healthcare Services in the state of California on providing the medical, and then we coordinate with Office of Emergency Services, and we utilize our mutual aid breakouts for that function. So as you can see, mutual aid was called in for the fires in 2017 in Napa and Sonoma County. We had 15 ambulance strike teams that IMSA helps coordinates and provides. Over 100 ambulances used. 13 counties were called in from different teams, as well as all the different disaster healthcare providers. So the medical impacts, we had 44 fatalities. We ended up having over 1,160 medical need evacuees that were housed in shelters all throughout multiple counties. And you can look at the different facilities that we had to also evacuate. One of the more significant ones was the Sonoma Developmental Center. And Marianne talked about how you could pick different alternative care facilities in the pull down of Pulse. Well, one of the things with that really came into use for the fires here that will in the future be very helpful is several of the shelters actually had to move. So you'd have an alternative care facility, number one, housed at Sonoma High at the address. Well, ACF1 would be moved. So you could actually still retain the ACF1 number, but now that it's moved to Sonoma College, you would go ahead and put in that address, which helps within tracking because Pulse does have a very robust audit mechanism. So if something needs to come back where patient care was delivered, we need to track who was providing that care, at what site that can be obtained. It's a very valuable tool within Pulse. So as I was saying, it just didn't let up for us. We rolled right into January, and the fires, because of the heavy rains, brought the mudslides that occurred in Southern California and the flooding. So caught our breath a little bit. So how do I implement this with all of this going on? So we were able to actually exercise Pulse with our end users at Moffitt in June of 2018. That was the first time I was able to do some in-depth training. And we started with what we call our CalMat teams in California. These teams are called in when we have major disasters. They actually become temporary state employees. And then after that, we look at also using our MRCs and our disaster healthcare volunteers. So I was able to train 80 people at this time down in Moffitt at the NASA base. So our goal was to train them on how to use Pulse, walk them through the whole situation, kind of do a mock staging tabletop type of thing. Then the following day, we actually drilled it. We were very fortunate. It was a full-scale exercise where disaster recovery was there, they had a building that was collapsed. Patients were pulled out of the building. And we had movie scene people who volunteered to come. I'll show you one of the slides here to do the mock wounds and cuts. It was very, very realistic what occurred. And then we'd have the flow coming in with triage tags. Patient movement would take place, the assessments. Their records would be pulled up with pulse. It would be paired with the patient all the way through whether they were going to be released, whether they were going to be transported by ambulance. And we actually had some patients that we went ahead and we transported out onto a C-130 in this drill. So you can kind of see what I just talked about in the movement. Actually, in the center, that is posed. That's how great they did with the burns and the different wounds that you could see. So very, very realistic environment. We learned so much from this exercise in so many ways. What we needed to be functional, one of the things that's wonderful about Pulse is the robust systems that it pulls down for us, but the problem with that also is in such austere environments, how do you quickly take that information? One of the most valuable things I actually played doing the DHV volunteer bedside when we were drilling it one night, first thing they want to know is what immunizations, because they want to know what tetanus, medication allergies. So these are the things that in phase 2, we're really going to work to try to extract some of those things that we can utilize in this type of environment that you wouldn't have the time like you would in a regular environment to pull. So now we go again, we're back into fire season, which happened earlier this year in July. And like Marianne said, I actually was at my dad's 80th birthday party, and all of a sudden everything started occurring again. And that's the one beautiful thing about this. And there's some, downfalls with needing internet connection, but I was actually with my cell phone at my dad's birthday party in Napa, able to call out to people, activate Pulse, get things going within about an hour for things that were occurring in Shasta. And we were mobilizing CalMat teams by late Monday afternoon to Shasta once we had requests coming in for the locals. So one of the things that occurred with Shasta, we got up there, they ended up having enough of their own staff with actually access into their own EHRs that our teams that went up there weren't needed. They were sent back within about 8 hours and came back. Then we had the fires that were occurring in Lake, and we really wanted to go ahead and have Pulse. So I actually had a couple teams of MRCs and DHV volunteers that were sent up there to Lake County. So we were utilizing Pulse. We were able to actually rely again on Sequoia and the great partnership, and with AI and all of us working, we integrated Sac Valley MedShare into it, which is a local HIO that had a lot of patients within the rural areas within Lake County. We were able to get that into the system. Also with Sequoia's help, we were able to get from eHealth Exchange, Dignity also, which had several within that area. So now we had more coverage up there. We started to utilize Pulse with the MRC that was driving up there every day from Contra Costa County. And then we had a norovirus outbreak. Actually, I was headed up there, told to come back because I wasn't going to get anywhere near or in the facility. So these are the types of things that we're constantly dealing with, trying to refine. But as I have the time to do trainings and more robust, we'll be able to refine this and have our staff trained. And that's really what it is. We've had so much occur in such a short amount of time of having these capabilities that we have to have the time to implement our policies and procedures and train our volunteers and staff, and also communicate and make sure that everybody knows this asset is available. So just as I talked about, those are some of my top 5 challenges. When I'm asked, what are your top 5 challenges? I'm always asked that. So I would say my number one thing that has frustrated me the most, but I think because of our partnerships and collaboration, I think I have a solve on it. And that's not geographically being able to cover California. And not only did I get that wish answered, but I'm going to be able now with eHealth Exchange and Care Quality and adding all these fabulous things to Pulse, I'm going to be able to actually treat patients that may not be California residents, who may be visiting and now be able to be reachable that we can treat in this situation. Sustainability and funding, that is always a challenge in anything that we do. This in particular, one of the things that I've been able to leverage when we have declared disasters, I have been able to leverage FEMA funding, and on an emergency basis for some of the connections that we did this last time, I just got approval to make some payments with that funding source as well. We just received a grant from CMS for quite a bit of money, but it does require matching funding. So we have $40 million we're funded, but I need to have $4 million in matching funds. And it has to come from private foundations or entities that are not connected and benefiting from Pulse themselves. So right now, I only have $1 million, I'm looking for $3 million, and I can go ahead and draw down another 36. So if anybody has any ideas, at the end, my number's there. More than willing to talk to you about that. So, like I said, sustainability is always an issue. Procurement process, maneuvering the procurement process is a maze. Luckily, I've been in state service for a long time. I kind of know the tricks. I know how to do that. But one of the things that's really frustrating is you get things working, you get them running, and guess what? Your 2 years is up and you have to go out for a whole RFO process. And, so how do you maneuver some of those things? So I field calls all the time, helping Texas, starting to help some of the other states with Pulse. That's something I'm more than happy to help anybody with, help you maneuver it. There's ways. We want to make sure we're doing fair procurements. We want to make sure we're following state processes. But there are ways to do that, refine that, and make sure that you have it in an organized manner that benefits everybody. Stable internet connection. That's something that we've had to deal with. It's austere conditions. You can't predict. So one of the things that we've been working on is using satellite. When we drilled it in the exercise, it was great. We have our own in-house communications person. He was fabulous working with me on some of those things, making sure I had a dedicated line when we were just trying to do that, making sure we weren't clinched down by different things with Wi-Fi. One of the other things that we're looking at is some Google balloons were used. Also using some drones to increase that type of thing. I'm not worried about it. We have to build it. We have to have this. FirstNet is something also that's available, and we're looking at seeing if we can pay some of our DHB volunteers to be able to have some of those chips placed into the phones, because you can also pull Pulse up if you have right now 3G, 4G. Well, FirstNet gives you dedicated line for 5G. So I think we've got, as technology keeps advancing, that's only going to help making this available in these types of conditions to pull those records. And then improve review of the functions. That's one thing, like I talked about before, really being able to get at the core of the information that you need for that medical provider right then and there, and extracting that out as quickly as you can. So talked about some of my next steps and where we're going, and happy to talk to anybody about what we're doing, how you can help us, and how we can help you with this process and utilizing Pulse. So next steps, like Marion talked about, eHealth Exchange. I also want to add additional connections. California is very unique. We have about what we consider 40 HIOs in our state. So we're trying to connect all of them into the system, as well as the bigger health systems as well. Patient tracking, that's another thing that's on my list. If you look here, currently, this is pictures from what was going on in the Napa-Sonoma fires. You have triage tags, you have the ins, and then you have this going with patient tracking. Got to have a better way to do it than this. It doesn't work this way. So, thank you.
Well, thank you, Leslie. Wow. It's just, I know, we were up here when you were going through the chronology of everything that you all were experiencing, and just the limited time you really had to respond. It's just impressive, and I hope you all can appreciate, just how this has been put to use. So Nora, I mean, tell us a little bit about what you all are doing in Texas. I mean, we obviously, there's interest and need, but you know, what's going on there?
There is interest and need. So I would say we're about 18 months behind where Leslie and California are. So you just take Leslie's slide and dub 2019 into it. Everything she had in 2017, that's sort of my goal. I think three things I want to let everybody know today. So for me personally, I was the governor's healthcare director during Hurricanes Katrina and Rita. My team was on the ground at the Astrodome with the physician's desk reference showing pictures of pills to evacuees, asking them if they recognize their blood pressure medicine. That is unacceptable in this modern age. We can do better, and maybe we have to have drones, although in Texas that makes me nervous. They might shoot the drones. Not so sure we're going to have drones overhead in Texas, but for me this is deeply, deeply personal because I was on the ground for those events. And it's funny, we're terrified of snow, but we do really well in other disasters like rain and other sorts of things. And I have 254 counties, all of whom have local control. So we definitely have some political issues that we have to navigate. The other obstacle that we have is that we have an unusual immunization registry in Texas. It is an opt-in registry. It is incomplete. It is incomplete for first responders. It is incomplete for children. That is, again, unacceptable. If you'd like to know why that is, bring me alcohol, and I will explain the backstory. I will not talk about that sober. But Pulse offers us some opportunities in emergencies to get around some of our state requirements that have interesting politics and no value in an emergency. So in terms of where we're at, I think there's several things that are important. Our governor's office has signaled their approval and support, and that's critically important to have high-level political support. Our legislature is not in session, but when they go in January, we expect to be talking about Pulse. We've had interim work groups. So we have a 6-month every other year legislature. Do not think that that's good. Do not try that at home because it forces that procurement cycle to really be ridiculous because by the time you're ramped up, you're back in session. And that is definitely a challenge. But they've been looking at Hurricane Harvey. They've been looking at state resources. When I meet with legislators about Pulse, the first thing they're asking me right now is, what do you mean we don't have this? This exists and we don't have it? Well, how do we get it? What do we need to do? And I have a list similar to Leslie's. Well, these are things that I need. I need support for statewide deployment. I need my Medicaid team on board, so that's data point number 2. Texas Medicaid has committed to working with us on an IAPD for Pulse. We're very excited. They've assigned some really talented folks to work on that project. Our state HIE, the Texas Health Services Authority, has really stepped up, and we have a secret weapon that I'm going to out because it's really not a secret, and that's Eric Heflin, for those of you that know Eric. Could not do any of this without you, partner. He is truly an extraordinary talent, and we're very lucky to have him on all of these projects, because it's back to sort of what Mary Ann said. We can't live in these verticals anymore. I don't have time, I don't have energy, I'm tired, I want it to work. I was raised by people very similar to Mary Ann's parents. So what do you mean you don't have a solution for the thing you're complaining about? Well, actually, we do have a solution. It's called Pulse. Let me tell you about it. So we're building political support. We're doing grassroots outreach. We have an operational work plan for pilots. So that's super exciting. And let me just close by telling you how granular we are. Leslie's going to love this. My health department folks keep asking me, well, what's going to happen if there's a Windows update that needs to be done at the shelter when you turn the laptop on? And it's does this ever happen to anyone in this room? When you need to print a document and Windows decides that's a great time to spend 3 hours updating your software? So, yeah, okay. So I would submit to you that's a terrible problem to have. Because if they're so bought in that that's what they're worried about, I've got them. They're in. They're in. That's a solvable problem. The internet connectivity is a solvable problem. Integrating HIEs into this is a solvable problem. Frankly, going to source data for immunizations, which is one of my goals for the project, so that we better support our emergency shelters. These are all, to me, solvable problems, and it's because of the good work of Sequoia Project. It's because of Leslie's leadership, where she's had to be the first one to answer a lot of these questions. We intend to learn from that and bring that to the table in Texas and bring Pulse up in Texas. And if, heaven forbid, there's an incident where we need it. Now, you may have heard that Austin has no drinking water right now. We're on a boil water notice in Austin because our lakes are 150% full and they've got so much sediment the plants can't keep up. So in my hometown, we're out of water, which, I'm shameless, is a great opportunity for me to talk about disaster response to everyone in Austin, where I need them to be paying attention. That's the hardest thing I think about disaster response, is getting people to focus when you're not on fire, right?
Yep.
But I think that the systemic work, doing this in a national way, having states like California lead, having the resources of Sequoia, gives me a resource to say, oh, I don't know the answer to that question, but I know people who do, so I'm never in a place where I can say, oh, we haven't thought of that. Yes, we have, because an enormous amount of work has been done sort of getting us to this place. So I have a high degree of confidence in our team on the ground in Texas. I feel like we're even going to get some legislative support this upcoming cycle, which would be amazing, because that really puts you in a good place when you start to work with your county judges and sort of down into the detail-y level. We're very excited about the possibility, and like I said, it's a terrible place to be when people are saying, why don't I already have it? I think that tells you something really compelling about the use case. And back to Mary Ann's point about sometimes you have to take those single use cases and work those cases to bring people along. This is one of the most compelling use cases that's available to us, and it's not a theory. It's real.
It is real.
And that is a fabulous, fabulous place for us to be. So I might be drinking bottled water for the next 6 weeks, but we're going to do Pulse in Texas.
Oh, there you go.
And that's how it's going to be.
All right. So Kristen, your role at ASPR is, really looking at it more globally with respect to, and you obviously have a lot of on-the-ground experience yourself. We've spent a lot of time talking about that. How does Pulse fit within ASPR's view and
I think the most critical thing is that years and years ago after Katrina, inherently people thought, you need to build a system. So what you got is these one-off systems of tracking beds and all this other stuff, which we were a part of that nightmare, and there's lots of people that have PTSD still from that experience and such. But one of the things that has to happen is that these systems exist every day. Being able to connect this information and us being able to flow it into a system that already works, whether it's from response or from your daily going about your business practices, right, your business model. Being able to converge those two things in a manner that provides readily meaningful, consumable, and actionable information, getting the right data to the right person, right tool, right time, and putting it in an environment. Why is Pulse really important? Why are these pilots really important? They are important because it gives the other opportunities of other states and other partners, whether even like at the local level, a chance to look, see, and do. So we're going to watch what you're doing, we're going to learn from you, and we're going to implement. And many people have said in the past, well, why would you do it incrementally? Or the fact that, you might not have it. And I think there's one point, there was a conversation about well, we don't have a lot of coverage there. I'm like, you still pulled records. That's 90 people's lives. That's important. And I think as it comes, data is going to become more portable. It's going to be transitioned. This is what the reality of our universe is. It will be there in time. The other things that you can look at are, what are the capabilities that you could do in time right now? We look at, from a personal experience, of every disaster, the top 3, 5, some would argue 3, 5, is prescriptions. Absolutely. Literally, in Sandy alone, in just one area, they had to do a prescription writing campaign and fill it. That was 37,000 individuals. It wasn't all of Manhattan, it was in one area in Red Hook. 37,000. If those individuals had not gotten their medications, this was 2 and 3 weeks in now, that would have been 37,000 calling for EMS and showing up in an ER. So when we start to think about that, the portability of information that we use on a daily basis, if we're able to put it in a structure that's secure and through a public-private partnership, the onus is off of many of the partners to figure out that. Let's be real. In government, we don't have the luxury of hiring the best and the brightest. Sometimes we get them. But in the reality is, we're not, go through all, we get them, but let's be real, you're way more competitive than we are for technology. We know that, we've said it repeatedly, we have to come up with initiatives every year. But the answer is, we don't have the capacity, we don't have the capability to readily create systems and capacities like you can. So why would we go and try and build something when you can do it? And the other thing is, it brings in the mechanisms and the expertise that you have, because you are doing this data exchange all the time. So if I'm not trying to figure out how to go through FSMA to do this, and I've done this, I actually had to do this with Medicare data to bring Medicare data to public health authorities through the Empower program and such. But if there's a capability that we can work on getting our partners, i.e. through state and local partners and also the trainees of the health credentials, like basically ASPR pays for the program called ESAR VIP, which actually credentials and establishes these required basically volunteer credential programs. They're mandatory across all states. It's through our programs. So here's where we can benefit and bring to benefit that capability, whereas technology comes there, and we're able to bring these two things together, and then we have the knowledge and the data that comes from you, that we can actually trust the data. We can trust the timeliness of the data. We can trust the information. I lived through multiple historic disasters. I've been doing this since 2005. Last year, you had unprecedented conditions. And we had, just in the first storm of Irma, we had to move 127 dialysis patients because we had a 24-hour period of time to move them out, or they were going to pass because they didn't have any access to healthcare. We moved them to Puerto Rico temporarily, hopped them over. We had to stabilize them in 24 hours. We had 24 hours to figure out how to take care of all the needs of 127 dialysis patients and get them treated and do their acute services. None of them had their medications. These are people that were severely chronically ill. They needed medications, they needed insulin, et cetera. They had been 5 days without insulin because their insulin was destroyed, their medications are gone. So we did this great job of getting them medications, right? We sent these teams in, we sent our national disaster medical teams in, we did this. We got the medications. We worked with the VA because nobody had co-pays, right? They had no money. So we did that. We're saving lives. Then unfortunately Maria came. We had 2 hours to put all the rest of those patients onto a single last plane coming off because we had to get them out of the area that they were in. 2 hours. Half of those patients didn't have all their belongings and left behind the medications. We had to start all over again. We couldn't get the information. So think of that. That patient went through how many cycles? The American Red Cross has a new protocol, this COTS cot. When people go into shelters, they have to literally go to the cot over and over again because people are so traumatized in a disaster. They don't remember life-maintaining medications until sometimes a day or 2 or 3 days in, and it's in a crisis. You know, when you see commercials, they say, what are you going to take? You know, every single disaster, you see the commercials come on with the insurance companies and say, what's the first thing you'll take? Or everybody says that. What is the thing that you're going to run out of your house? Fires. What is the thing that you're going to grab out of your house? What does everybody say normally? Photo albums?
Pictures. Their pets.
Does anybody ever say they're pharmaceutical? No. But yet they rely on them to prevent heart attacks, prevent strokes, etc. So this is the challenge that we're faced with. And yet here we have a capability that we can work collectively together. Now on our side, on the federal to the state and local that I deal with every day, it's new to us, right? It's new to us to try and figure out how to do that, how to work that in, get the lawyers on board. You know, we love lawyers. Sometimes we don't like lawyers, but we try. But how do we do that? And that's where we are now. And I think the beautiful part is you may not see suddenly an entire map lit up overnight on implementation, but that's okay because it's coming. And as soon as you have really solid pilots like these and you have experts that actually can explain it, you will have pickup very quickly across the country. And I can speak to that because I did the Empower program. And basically we took Medicare data, we got Medicare to actually provide their data on electricity-dependent populations that are ventilated, concentrator, home health dependent, dialysis dependent, oxygen tank dependent, the individuals that show up in every ER, first phone call in. And we were able to do that, and initially public health was like, whoa, how do we use this data, like HIPAA? Like, well, it's disclosed to you under HIPAA. We're allowed to actually give it to you because of HIPAA. So there's no HIPAA challenge.
What?
Yeah,
What?
There's no HIPAA challenge, believe it or not. So the initial answer was like, okay, I have to figure this out. We have use of de-identified data across the entire country. We have pilot after pilot after pilot, and then we have literally states that are now calling it in 2 hours I can give them Medicare data. So now you take this where you can deploy a team, and we have the National Disaster Medical Assistance Team. We have 4,500 clinicians that work in your hospitals across the country, and then they say, you know what, I'm going to volunteer. What if you trained all of them so they can walk into an ER and automatically find that record? There's probably nobody in this room that hasn't had a direct impact of some sort of disaster, incident, or emergency in your lifetime or somebody close to you. And when somebody says, what's the meaning of one person? Think about your loved one that was impacted. That's to everybody. So when you say 90 records, that's 90 people's lives. That matters. It changes. It changes. And it will be more and more and more people as time goes on. Because the disasters aren't simplifying and weakening. They're just coming at us. And now we have hurricane season on both coasts, like 15 at a time. So this is where I think we can collectively come together. And I think the technology and the capabilities that you have, where we're able to incorporate them into technology such as Pulse, putting in the right protocols like you've done. You've spent so much time putting those protocols in, protecting privacy, making sure that's there. The portability of that information to put it into a clinician's hand right away and be able to answer the question is life-changing. And not just for the individual in front, but for every person standing in line behind that person. And there's lines of them that need help. The triage capabilities. It changes everything. This is going to change disaster response for the future. And it's doing it now.
So who's not convinced? So you can see why these ladies are on the advisory council. I mean, we are very, very lucky to have their involvement. I know we're just a couple minutes shy of noon, and we do want to keep to the schedule, but we can take probably one or two questions if folks have any questions. Teresa. They're going to run as a race.
Okay.
Matt or Eric?
It's the saddest race in history. I love this. Thank you for your presentation. So is there an easy 1, 2, 3? This is how you do it? I mean, how do we sign up?
Yeah.
Well, I mean, definitely toolkit and steps and things like that. I wouldn't say we have a whole full toolkit that we can give you at this point because we're still implementing. One of the things in my next steps is our disaster healthcare volunteer manuals right now. Pulse is being implemented into that, our user guides, as well as for our state guides. Also, Hospital Incident Command. I've been approached, a lot of the hospitals are wanting in California to make Pulse a component of that. So we're in that process, but I definitely could provide you, information and, the get started types of tools. And then, I mean, why reinvent the wheel? Actually, sometimes when I get calls from different states, I'm like, sure, here. So I just start sending, and like, wait, hold up, you sent me too much right now, and things are bogged down. But I definitely can send you any resources that I have available and get you going.
I think the key is to get the state and the authorities buying and who's going to champion it, make sure they have the funding for it, and then it's a matter of just implementation. It's that simple.
And just building on that, I think the unique thing that Pulse brings is it also creates a new collaboration from my universe, which we call Emergency Support Function 8, which, what does that mean? The National Response Framework. Public health and medical is owned by HHS. So we coordinate anything that's public health and healthcare related from federal for disaster. So we have directors at every state. They call them usually the ESFA director or preparedness directors. They're now talking to their Medicaid agency directors. They're now talking to their HIE directors. This is a pollination that hasn't really, it's been, in some places, yes, it happened, but few and far between. And now we're finally putting the powerhouses together. So you're bringing the data, the technology, and the groups together to understand, but then also be able to systemically implement this. So, there's a couple pilots here to start. It's going to turn into, then it'll get picked up and grow. But you're now bringing the right people into the room, and they're starting to learn how to speak each other's language and adopt that. And that's life-changing.
Well, and the last thing I'd add to that is I don't know that this is on the radar of every Medicaid program.
Yep.
So imagine how much fun it would be if you're the one that tells them about it.
We've been hitting them on the high-tech side. I can assure you that with my friend. But on the regulatory side.
They don't always talk to, to that question about bureaucracy.
The broader.
They don't always talk to each other, and so we've seen this a lot, that it's over here, but it's not over here, and it's not over here, and the power of leadership and convening is everything.
So I do think we have time for maybe one more question.
So as far as how to get up and running, Teresa, just file a support ticket or send an email to Marianne. give us an hour, be up and running. So actually, we do have a question.
So how do we get our repositories of our clinical EHRs hooked up to Pulse? I know we can go through eHealth Exchange, but we have to work with somebody to hook up that last section.
Oh, well, Pulse actually just would have to integrate with the state's database, and then it automatically connects to the eHealth Exchange.
Automatically?
Well, there have been tests to just make sure, usually it's connection tests.
So-
Well, the next thing we need to do is actually test and certify Pulse to the eHealth Exchange validated program, and it would get a little bit more turnkey.
Okay, so you're not ready for us yet? Because
We're
I'm happy
ready.
to bring on 28 states right now.
Yeah, well, why don't we get you guys where you should be? I mean, yeah,
Yeah, and actually it uses the eHealth Exchange registry. So
Perfect.
yeah.
we have one more question.
One more question, Stephen.
There was a hint made earlier about moving beyond the disaster healthcare volunteers and the alternative sites and looking at using Pulse to actually connect to provider offices, to hospitals. Any sense of what the timing for that is going to be?
That is second on my list on the priorities for California. Right now, and that's one of the things too, talking about the ESAR VIP. I've been able to take our ESAR VIP program and then pair the funding that I had for Pulse separately without commingling the funds and being able to maximize the dollars. So within our contract with the ESAR VIP, we've already been in discussions with our vendor for our DHV site. They've already started plotting in areas where we can start doing that registration in different categories. So right now we are working on that. Once I can kind of align the Pulse side, which I'm just about ready to get authorization for our 90/10 funding through the state to start doing that. Those will marry up. So I'm hoping within about 2 months I'll be able to start contacting the hospitals, and we're trying to work on a system where we'll get a list of those entities who need to come in to the system, and then we'll just have it put in so we're not going through the process that you and I went through late at night one night when you were trying to register it. It was so erroneous and took such a long time to do.
And I just add on that, it's critical, right? Because emergency department decompression, every single day, if you call your doctor before 8 a.m. or after 5 p.m., it says what? If you're having an emergency, please hang up, dial 911 and go to your local emergency department. We've trained everybody really successfully on that, and they really do like to go to the emergency department, and that's where we have crisis because we don't have alternate destinations and such like that. So that's something we advocate and support for. What she's doing is incredible. The other thing is remembering that you do have a lot of emergency docs and others that will be state credentialed volunteers, and as we think progressively about that when they're in their volunteer role or whatever, and look at where there's cross-pollination there. So we start to actually have individuals across your entire states and localities that, hey, I've been trained on this thing. Let me tell you why it's really important. Let them be the advocates. They use it, they see it, and they know they can move patients faster because there's always a line behind them. So it's really trying to be progressive, and we have an emergency care coordination center across in Asper. We look to try and initiate this, and this is also something that we're really positive about as well. We look at ED decompression in any way, shape, or form we can do it. We usually use our National Disaster Medical Assistance teams. We'll deploy to an ER to decompress. So we look at it from the opportunity we have with our own workers.
All right. Well, I know there are probably lots more questions, and there's a lot more time we can certainly spend on this, but thank you all very much for your time today. I think this does conclude our program, so thank you.